Hello everyone, my name is Dr. Harem Jafar, Assistant Lecturer in the University of Suleimani. The summer session lecture is about gingivectomy and gingivoplasty. The content of this lecture is regarding the definition, indications, contraindications, types of gingivectomy, and the healing process. Definition, indication, contraindication, types of gingivectomy, and healing process. Regarding the definition of gingivectomy, it's the excision of a portion of gingiva usually performed to reduce the soft tissue wall of periodontal pocket. The excision of gingiva by removing the diseased pocket wall, thereby exposing the tooth surface, which provide the visibility and accessibility that are essential for the complete removal of irritating surface deposits and thorough smoothing of the root. So the main aim of the gingivectomy is by providing the visibility and accessibility, by exposing the tooth surface to be accessible to complete removal of any irritating surface deposits and thorough smoothing of the root surface. The main objectives are, first, to eliminate the pocket, then to achieve a normal architecture of gingiva, and third, to provide a visibility and accessibility. Or sometimes for the correction of asymmetrical or anesthetic gingival topography. Like as we see here, the height of free gingiva here is higher than that of here, so it will need correction. The definition of gingivoplasty: it's a surgical reshaping of the gingiva to create physiologic gingival contour in the absence of pockets. So it's just reshaping of the gingiva. Indications of gingivoplasty: the presence of any deformities in gingiva as a result of gingival and periodontal disease, gingival clefts and craters and shelf-like papillae, like in case of acute necrotizing ulcerative gingivitis or in case of gingival enlargements. The technique is by tapering the gingival margin, creating a scalloped marginal outline and thinning the attached gingiva, creating a vertical ID grooves and shaping the ID papilla. ID is the meaning of interdental papillae. The indications are suprabony pocket, gingival enlargement or false pocket, crown lengthening in case of aesthetic consideration, and suprabony periodontal abscess. The local contraindications includes infrabony pocket as present here, infrabony pocket, or inadequate width of attached gingiva, when the width of the attached gingiva is inadequate, because if you excise the attached gingiva, you will end up with a gingiva without keratinized tissue. And when you have an aesthetic consideration, Example, if you excise a gingival tissue, you will end up with the recession and elongated tooth. And when the base of pocket located apical to the mucogingival junction. When the base of pocket, for example here, located apical to the mucogingival junction. This is the mucogingival junction here. When the pocket extends beyond this line, you can't do gingivectomy. While general contraindications includes poor health of the patient or patient with a debilitating disease, patient having systemic diseases like hemophilia, diabetes, leukemia, but surgery can be performed with consultation of the physician. Also, patients on anticoagulant therapy or patient on drugs taken for gut. In all these cases, the physician consultation is needed. Types of gingivectomy. We have 5 main types. First of all, we have surgical gingivectomy, which means the gingivectomy did by hand with a hand skill, and a gingivectomy by chemosurgery, and gingivectomy by electrosurgery. Fourth, gingivectomy by cryosurgery, and finally gingivectomy by laser. The tools needed for surgical gingivectomy are pocket marker, Kirkland periodontal knife, Orban periodontal knife, blade number 11, 12 or sometimes 15, supra and subgingival scalers, curates, and surgical dressing. As you see here, this is a blade number 12, and this is a Kirkland periodontal knife. This is an Orban periodontal knife. This is surgical hoe, and this is a curate. Well, these are diamond bears used for reshaping in case of gingivoplasty. Steps needed in surgical gingivectomy. First of all, we need to do anesthesia. Second, marking of the pocket with the pocket marker. Third, resection of the gingiva with the Orban periodontal knife or with the blade. Removing granulation tissue with a curate or scaler, and removing the calculus, and finally placing the periodontal pack. We should start apical to point marketing of the course of periodontal pocket. First of all, we mark the area, and it's directed coronally to a point between the base of the pocket and the crest of the bone. And it should be close to bone but not exposed it. The incision should be beveled at approximately 45 degrees to the tooth surface to follow the normal festoon or the normal architecture of the gingiva. But it should not leave the diseased pocket wall. This incision should pass completely through the soft tissue to the tooth. This is the local anesthesia. This is the pocket marketing. This is how we mark the area with a pocket marker. This is the pocket marker here from the side. We explore it first of all with the periodontal probe, and after that we mark it. We mark on each tooth 3 places on each tooth for each labial and lingual surfaces. And the pocket should be marked systematically, beginning on the distal surface of the last tooth, then moving on the facial surface and proceeding anteriorly to the midline. So you start from here till here, and from here till here. You start distally to the midline. This is the pocket marking. Regarding the types of incision, we usually use internal bevel incision, which it may be continuous or discontinuous. The discontinuous one start from the distal angle of the last tooth to the distofacial angle of the next tooth. From here to here. Yes. Then the next excision begins in the interdental area to distofacial angle of the next tooth till here. And the procedure will be continued like that. While in case of continuous one, we start on the facial surface of the distoangular region, like for example from here. We start from here and we go forward anteriorly, following the course of the pocket marking without interruption. And if we have the lingual or palatal swelling, so the procedure is repeated on the lingual surface also. This is the procedure. For example, in case of continuous one, we made the incision from the distal angle of the last tooth, and we begin continuous incision on the course of the pocket marking. Then we excise the soft tissue, the excess soft tissue with Orban knife, and here we found the one piece of continuous internal bevel incision, the excised tissue here. After that we apprise the filled bead-like granulation tissue. We remove the granulation tissue and the calculus remnants, and we softening the root surface. We soften the root surface and cement them from any protuberance to make a clean, soft area, to not be a breeding area of bacteria, and make it accessible for oral hygiene. This is the gingivoplasty with a burr. We reshape the interdental areas and excess gingival tissue to go with the normal contour of the gingiva. It's a tissue trimmer, it's a burr, it's a cutter, laser. After that, the periodontal dressing is placed. We also do gingivectomy by laser. Here, in case of laser, actually there is a minimal amount of anesthesia and the procedure is completely bloodless, and it's easier and less frightened by the patient and more acceptable, but it's a little bit time consuming, but research found that the gingivectomy with laser have a good result than the blade. Gingivectomy by cryosurgery. The cryosurgery is a machine work with the cryoprecipitation, where the temperature is to -50 to -60, is applied to gingiva by means of a probe, and the procedure is painless and without bleeding. Gingivectomy by chemosurgery. First of all, we can use phenol 90% plus alcohol 95 to 99%, or 25% phenol with 75 camphor, or 35% paraformaldehyde in zinc oxide eugenol pack. Gingivectomy by chemosurgery, the advantages are no analgesia or anesthesia required for the procedure, and the procedure is easy to perform and require less instruments. While the disadvantage, you may get a bone necrosis or periodontal abscess may result, delay wound healing, and you may get a plug retentive area and also bone resorption. Gingivectomy by electrosurgery, the indications are to remove the gingival enlargement, or gingivoplasty, or relocation of frenum and muscle attachments, or incision of abscesses, or pericoronal flaps. While contraindications of electrosurgery, you can't use electrosurgical machine in patients with a pacemaker and unpleasant odor, and the procedures that involve proximity to bone, because heat may cause tissue damage and cemental necrosis, because if it touches the bone it will cause a bone damage. The advantage of electrosurgery is to control tissue hemorrhage and there's adequate contouring. In case of gingivectomy by electrosurgery, some researchers said that in the healing there's no significant differences with the other procedures, while other researchers said that the delay healing, greater reduction in gingival height, and there's more bone injury. So in all these 5 procedures, I guess the laser is the best one nowadays, because it has no disadvantages. It's just a little bit time consuming, and from a psychological point of view it's more acceptable by the patient, and it's painless and a bloodless procedure, and you may get a good result and a good healing. So instructions for the patients after the pack are placed. First, the pack should remain in place until it's removed in the office at the next appointment. For the first 3 hours after the operation, avoid hot food to permit the pack to harden. And don't smoke. because it delays the healing. And don't brush over the pack to remain the pack stable. Regarding the healing after surgical gingivectomy, the initial response after gingivectomy is clot formation. Then the underlying tissue becomes acutely inflamed with some necrosis. The clot is replaced by granulation tissue after 24 hours. Increase in new connective tissue cell, mainly angioplast, beneath the surface layer of inflammation and necrosis. By third day or 72 hours, numerous young fibroblasts located in the area and highly vascular granulation tissue grows coronally, creating new free gingival margin and sulcus. Capillaries derived from blood vessels of periodontal ligaments migrates into the granulation tissue, and within 2 weeks they connect with the gingival vessels. After 12 to 24 hours, epithelial cells at the margins start to migrate over the granulation tissue, separating it from the clot. Fourth, the epithelial cells advance by tumbling action. Finally, the surface epithelialization is generally complete after 5 to 14 days. This is regarding the gingivectomy and gingivoplasty. Hope you are interested in it, and thanks for your listening.